Leslie. I just go by Leslie. I'm a genetic counselor. Has anyone seen a genetic counselor? Okay, there's about 4 in the city now. So at one time there were 6. So we've dwindled. So I left clinic in July, but I'm just going to talk a little bit about BRCA and breast cancer. I'm pretty informal, but last time I spoke for this organization, there was a really good Q&A at the end, and so my talk is actually pretty short. I'm going to breeze through it pretty quick, and then we'll go to a Q&A session. At that time, if you're uncomfortable, we can shut off the video so that you can really ask questions that are good for you, your family, your friends, whatever questions you may have. Okay? Sound good? Like good plan? We already talked about that. So I do work for a laboratory, so a lot of things I'll use in this are tests from my laboratory, but they are tests that I also ordered a lot on the clinic side. So I always let people know that, just so you know that I am employed by a diagnostic laboratory. It's not really a conflict. I try to keep it apart from things, but I will be using that language. So we're going to discuss some options for BRCA testing. How many have had genetic testing? Everyone? Okay, yeah, and depending on when you've had it, most of you have probably not had the same test. That's how quickly genetics has changed and how quickly genetics updates. And so then we'll also discuss some take-home points to talk to your family about and to talk to your physicians about, so that as the growing landscape changes for genetics, you can continue to get testing that you need, okay? And then the Q&A, and there is a disclaimer, this is not medical advice. Always go back to your doctor with questions that we discuss here. If there's something that you're concerned about, it's something that they should be addressing as well, okay? So, hereditary cancer. First, we need a crash course in genetics. So, I went to grad school for 2 years for this. You guys are going to get it in 2 minutes, I promise. So, we know that of all cancer types, about 5 to 10% are hereditary. So, what that means is we see a pattern of cancer that runs in the family, and we identify a gene mutation that can explain that pattern. We don't always find a gene mutation. I'm sure you've talked with people either in your treatments or you know friends or family where they have a lot of cancer in their family. Maybe they've had genetic testing, but it hasn't given them any answers. The fact of the matter is there's 20,000 genes and we're just not that smart yet, but we're getting a lot better. So for most people, we are born with 2 copies of every gene, one from mom and one from dad. And as we go on in life, we do things like party in college and lay in the sun in baby oil and get shellac manicures, right? All of those things that are tough on our bodies. And so one of those genes wears out, but we're okay because we're still covered with one working copy. One copy is still keeping us healthy. But as we age, which is the #1 risk factor for cancer, and as we continue to do things like, I don't know, maybe pick up smoking or try the new wine line at HEB, who knows, we get that second hit, and then that's what goes on to establish a cancer usually. It's called the 2-hit hypothesis. See, you're all smart, you know everything I learned in 2 years. In hereditary cancer, instead of being born like this, you're born like this. It's a spontaneous change. There's nothing mom or dad could have done to prevent that change. There's nothing mom or dad could have done to give you that change. And so you're kind of already one in the whole. So as you do the things that everybody else does, college, manicures, you get that second hit sooner. And that's why people with hereditary cancer are more likely to have cancer at younger ages, or it may be more likely to be an aggressive subtype. Does that make sense? See, you guys are so smart. So these are features when we think about who could have hereditary cancer. We always look at personal and family histories for these features. So, and this is specific to breast, but there are multiple features that go across tumor types that are very similar. So young diagnoses, bilateral or multiple primaries, so maybe someone had a breast cancer and then years later they had an ovarian cancer. Male breast cancer, so that would be like a very rare type of cancer. Multiple primaries, I said that, or family members who have multiple primaries as well. So you can kind of see multiple, rare, and young are kind of the 3 tenets of hereditary breast cancer. And a lot of people know about the BRCA genes. BRCA1 and 2 are the most commonly known genes for hereditary breast cancer. So true or false? We all have the BRCA genes. Yeah, and you were going to say false, right? So this is, in the media, this is like my #1 pet peeve when it comes to genetics. I'm going to delve some personal information into this talk. So when you watch NBC Nightly News with no longer Brian Williams, but with Lester Holt, very sad, right? When you watch it, they say people with the BRCA gene, and they're talking about all these cancer risks and all these decisions women need to make. Well, I'm here to tell you, we all have the gene. It's whether or not it's functioning, okay? So this is absolutely true. The cancer risks are known when we have mutations in the gene, or maybe we have a piece that's missing or added that's causing that gene not to act the way it should. So BRCA 1 and 2, we've known about them for a long time, since the mid-90s. They were cloned in the University of Washington with Mary Claire King. She's brilliant. She's one of my heroes. And we started doing testing in the clinic setting, so not in a research setting, in the early 2000s. And there was one company who was able to do it for many, many, many years, Ambry Genetics. They did very high quality testing. They have the most information on BRCA, and they were able to really provide patients with answers. But we know that there's other things out there. We know that BRCA can cause marked risks. So individuals with mutations, so, have the blue risks, so marked increased risk, versus those without have the gray risks. So you can see why people would want to know this information and why laboratories were passionate about making this information available to all patients. So in 2013, it was a hallmark year, June the 12th, I remember it like the back of my hand, the Supreme Court overturned a gene patent on the BRCA genes. This was a huge day in genetics. The month prior, Angelina Jolie did her opinion, her op-ed in the New York Times about her bilateral mastectomy. People remember that? So in my clinic, I was still in clinic at the time, we were swamped for May because everyone saw Angelina and were curious about their risks, which I'm so happy she started that conversation, but good gracious, were we busy. And then in June, this really savvy patient said, well, I couldn't get the test before because it was too expensive or my insurance didn't cover it. What are my options now? So on June 12th, the patent overturned, and June 13th, Ambry Genetics accepted their first sample. So it's been a very interesting time in cancer genetics since the patent overturned, but it's also a very exciting time. It's allowed to reduce costs and allowed for people to have the most comprehensive testing they need up front. So that was a huge year, very, very exciting. And it's important because we know that BRCA, this is all hereditary breast cancer, BRCA only accounts for about 50%. So if you've had BRCA testing, we've looked at about half of what we know could cause hereditary breast cancer. If we look at some other genes that are on some multiple genetic tests, are not just Ambry's but multiple tests, we know we can explain about an additional 30% of breast cancer. So like I said, we're still not smart enough. There's always going to be this gray piece of the pie that we all get annoyed with, that we can't provide everybody answers. But if someone wanted the most information that they needed before the patent, we would have to do BRCA 1 and 2 testing, wait for the result, and then order additional testing, wait for the result. A lot of times patients, as you may have used these results, use them to make treatment decisions. So now we can do testing on one shot in the quickest way possible to look at all of these genes. Does that make sense? Okay. So what have we been missing? I'm going to give you the 3 most common other high-risk breast cancer syndromes. So these are what we call BRCA-like because their breast cancer risk is as markedly high as a BRCA. But BRCA can have risks of breast and ovarian cancer, whereas some of these have kind of other cancer clusters. And I don't want you all to get afraid and think that you have Li-Fraumeni syndrome or Cowden syndrome or hereditary diffuse gastric cancer syndrome, because these are far more rare compared to BRCA. So Li-Fraumeni syndrome caused by changes in the TP53 gene is known to cause a lot of cancers. So we say the lifetime cancer risk is about 93%, which is very high. Most people with this condition get 2 to 3 cancers in their lifetime, depending on their survival from their previous cancers. Okay? Historically, it's been thought to be a childhood syndrome. You know, kiddos can be affected, which in BRCA we don't see. And historically, it was thought to be a cluster of brain, breast, bone cancer, and a rare tumor called adrenocortical. It's just a big word. And so now what we're seeing, because we're able to look at people at this gene more often up front, we're seeing that it doesn't always look that way. So we're learning a lot about these genes kind of on the back end because we can look at them all at once since the patent has been overturned. Cowden syndrome is a little more common. The breast cancer risk isn't as high, but it has a smattering of other cancers as well. Colon, thyroid, uterine are kind of the big hitters in that, but it can also have features like lots of lumps and bumps and a big head. And in clinic days, we always had breast conference, and someone would present the family history. You know, we have a person with breast cancer, and she had uterine cancer. Her mom had thyroid. You know, so I'm kind of thinking, like P10 Cowden. And we would always ask, do they have a big head? And all the physicians would laugh because they say, how am I supposed to gauge that? So it's a funny, but it really is a trait. So if you've always had troubles wearing hats, who knows? CDH1 is also a very rare cancer, and it's more specific to the lobular type of breast cancer. So we're probably mostly aware that there's, many subtypes of breast cancer, ductal, lobular. And so this one, again, we're kind of changing the way we think about it because we're seeing people have mutations in this gene that don't fit this picture, okay?
Is that Lynch syndrome?
Ooh, you're savvy. It is not. So I have not included Lynch syndrome here, although that is my I almost said my favorite genetic syndrome, and that's not right, but it is my most passionate genetic syndrome, is what I am most passionate about. Lynch syndrome is caused by one of 5 genes, and it's historically a colorectal syndrome. But it can be similar and be tested for in someone who may also have BRCA testing because it has ovarian cancer with it as well. So the big 4 for Lynch are colon, uterine, ovarian, and stomach. So anyone who's got kind of that gastric or ovarian cancer history, we usually look at both. Okay? You're super savvy. If people wanted any of this testing, they would have to get their BRCA testing, likely get a negative result, and then return to clinic for additional testing. Then let's say they needed additional testing. They would get the negative result and return to clinic for additional testing. And so we know this isn't optimal. I know a lot of times folks go through lots of appointments when they have a cancer diagnosis, but if, let's say you're just going to better know your genetic risk, it's a lot of appointments, a lot of time, a lot of money. A lot of times we would lose these patients when they would need additional follow-up. So Lynch syndrome is a great example. We would have an ovarian cancer patient. We would need to do BRCA testing. Okay, it was negative, return to clinic. Do Lynch syndrome testing, it was negative, return to clinic, and probably do one more test as well for them. So now we have the capability to take all these genes and do what's called a multi-gene panel test or panel testing. Has anyone had one of these? No? It usually looks anywhere from 5 to 28 to 43 to 108 genes. So we can look at all of these high-risk genes at once to be able to give you that answer as soon as you need it. So this is actually a panel that we offer. It's called BRCA Plus, and it looks at all the high-risk breast cancer genes. And the goal is, if you have that surgical decision pending, or you just have decisions about how you want to do your treatment, we can know if you're at super high risk before any of that begins. And we can do all of these genes in 2 weeks. Okay, so it's fairly quick. And there's a lot of benefits of panel testing. Like I said, there's many different panel tests on the market. We'll talk about a few just through Ambry. Again, not to be conflictual in any manner, just to provide some education. So really with panel tests, we're learning a lot about the genes like I was alluding to with the Li-Fraumeni and the Cowden and the diffuse gastric syndrome. We're learning a lot about those based on the people who are being tested for them because they're not fitting the criteria we usually met. So we're able to identify those people who need additional screening, who may not have gotten the testing before. Maybe they had returned to clinic 5 times and they were never able to get the test that they actually needed. And then we can also individualize their screenings based not only on their genetic test result, but also the family history. I always encourage people that yes, if you do genetic testing, there is that test result, but the most powerful tool at your dispense is that family history, okay? A lot of times we need to look at both of them together to get the best management for you. And then we can also target therapy if we know that there are specific mutations. So There's a new drug out for late-stage ovarian cancer individuals who are BRCA positive, so that's exciting. We can now use this information to really treat the patient, not just know a risk that could or could not happen. And we know, like in that Li-Fraumeni syndrome, just the way that gene works, we know that those people should avoid radiation. So for those who are familiar with breast cancer, a lot of times an option may be lumpectomy followed by radiation. Well, if someone has that gene, is that really an option for them? Okay. So I don't know how well you can see this. So this is a lot of mutations of those 5 high-risk genes, and this is the important part. So if we look at clinical criteria, so I went through like some of those bullet points for hereditary cancer. Those are mostly for BRCA 1 and 2 testing, and then a lot of these other syndromes have, if this, then that for testing, okay? So when we look at people who are positive in non-BRCA genes, so they're positive for these other 3 genes we've been talking about, 2/3 of the time they don't meet those criteria, okay? So what that means, like I said, is we're rethinking how we're thinking about these syndromes, but also if we're just going by the criteria, we could be missing the causative mutation of what's going on in the family. Does that make sense? Okay. You can turn it back on. So I think you need to consider things if you're ever thinking about expanded testing. So obviously, I like the panel test. This is something I used a lot in clinic. It's something a lot of my providers use. It's something that can provide us answers in unique ways that we didn't really have available much before 2013. But if you're considering this test or you're considering any genetic testing, you need to think about the types of results you could get. So it's important to understand these are still rare conditions. Only about 7% of all individuals diagnosed with breast cancer will have a BRCA mutation. So if we have 100 people in a room with breast cancer, only 7 of them will have BRCA 1 or 2 mutations. Even fewer will have the other genes we've talked about. So it's still important to realize that this is rare. Again, we have 20,000 genes, we're not smart enough. I could say that all day, but it's still rare, okay? It's also important to consider how okay you are with uncertainty. In genetic testing, it's not just black or white. It's not positive or negative, okay? There's this really fun gray area called inconclusive, and that's where we find a change, but we don't know what it means. Maybe we've never seen it before. Maybe we haven't seen it enough to be able to call it one way or the other. And it can be uncertainty for years because usually we just have to wait for someone else to also have that change and a similar family history or a similar personal history to be able to tip the scale one way or the other. Okay, so that's really important to consider. You also need to consider how much information you want to know. So there are a lot of different genes. The 3 we've talked about in addition to BRCA, remember I said they're high-risk breast cancer genes. We have a lot of other genes that aren't as high risk as BRCA. Maybe they have a 2 to 4 times risk of breast cancer in your life. So that would be, a roughly 24 to 48%. Most of the time it's lower than that, okay? You also need to realize that sometimes we don't know how to manage these genes and conditions, and sometimes we don't have management guidelines that will help your insurance company cover screenings that we feel are necessary, okay? And then you also have to realize that while you might want this test because of breast cancer, there's usually a smattering of other cancers that are included. And it's important to ask your doctor and to think to yourself about what those other cancers may be and how you feel about them moving forward. So we've kind of talked about this, the pros of, expanded testing or more testing beyond BRCA. It's more likely we're going to find something. It's more likely that we would find a mutation we wouldn't if we didn't use expanded testing. It's time sensitive and it's cost effective. The cons, though, we may not know all the risks that come out of the test. There may not be guidelines. There's an increased rate of that variant of uncertain significance or that uncertainty, and it may have other cancers that you're not prepared to deal with or that we're not prepared to manage. Okay? So this is just an example of some of the panel tests that I've been talking about. So we talked about BRCA 1 and 2, and then we have this high-risk BRCA plus panel. That's the 5 genes we've been considering. The next step up is breast next, which is 17 genes, and then we have Cancer Next. So I'm just going to run through a case example so you can kind of see how all the testing options that are out there could be used, but also how it can get muddied very quickly, and how we really need to be thoughtful when we're pursuing this testing and in the conversations you're having with your physician. So BRCA 1 and 2, we know them. I will say we're learning a lot about them still, but we know them very well. They're well established, they have common risks, and they have common guidelines that many people are aware of and follow. But if we just do that testing, we've seen we may miss a causative mutation. So maybe we move up to the 5-gene panel. It's a high-risk panel. It increases the likelihood we'll find the mutation that could be causing cancer in the family. It has a low inconclusive or VOS rate, so low uncertainty rate, and it's high-risk genes with guidelines. It's a great panel. But maybe you want more. Maybe you have family history and breast cancer, and you just think there's something going on and there's got to be something to be done about it. Well, then maybe Breast Next is for you. So that's 17 genes. So it includes all the high-risk genes and then a lot more genes, so 11 more, 12 more, that have some of those funky risks. So, increased risk, but how do we manage, okay? It could give you the answer you're looking for, but is it really the answer you're looking for? It has a higher risk of uncertainty. Anytime we look at more genes, we get more uncertainty, okay? And not all of them have guidelines. In fact, most do not. Now let's say you had all that breast cancer in your family, and then you also had ovarian and stomach and some other random cancers like leukemia or brain or colon, just kind of this, all these smatterings of cancers, but you still feel like there's a pattern. Well, then we can do something called Cancer Next, and that's where we look at a lot of cancer syndromes in one place. So it's not specific to breast cancer. So then you're really opening up the gate to uncertainty, cancers you may not be ready for, and also not having guidelines. So those are kind of how there are multiple different options, and that's why I say when you think, a lot of people say, I'll get a test, like I just want to know. And so my job in clinic was to say like, well, how much do you want to know? And kind of walk through them with that and what it would mean not only for them, but their families. I always say a genetic test is not a white blood cell count. It's not labs, right? It's not just you. It's your kids, it's your siblings, it's your parents. And so it does take some time to be able to move through these channels. So again, I think I've hit on this, things to consider, things I would consider if I was pursuing this testing. How much information do I want to know? And that's a really hard question to answer, right? Because our general understanding of what this could mean is not very good. And so it's hard, then you go to the internet, and then you find stuff you shouldn't find, so it's tricky. But ultimately, you need to ask your physician, would it impact my care, Because sometimes when we identify this information, people think, oh, I can get this drug I thought I could get, and you can't. There's not a lot of targeted therapies out there related to genetics at this time. It's our hope, of course, that we'll get there. I also think you need to consider if your family would be interested in this information, because if you do test positive and you're sitting around the Thanksgiving table and you say, hey, by the way, I've got this thing called BRCA, people are going to get anxious and people are going to want to know their risk, or vice versa, they may not care at all, and you have to be ready to deal with that too. And then also, are you okay with uncertainty? So when you need to consider this testing, so beyond BRCA, if you have additional personal or family history since the time you've tested, all your relatives are continuing to age, know that cancer is a normal part of the aging process. Like I said, age is the number one risk, not BRCA, okay? But we need to, as those are updates, the testing is updating and your histories are updating. So it's important to always have that conversation. Just like I tell all my clients, every time your patient comes in, they get their blood pressure taken, right? So then you should be talking about their family history as well, okay? If you've had incomplete BRCA testing, so a lot of people know about the BART test. Does that ring any bells for anyone? Okay. It's just a different way of looking at the genes, but it wasn't a comprehensive test for a very long time. So it's important to ask your doctor if you've had that. And also if you want more information with my asterisk of everything from the previous slide.